think we're expecting Dr. Natarajan to join any moment. So request you all to be patient for a while. Thank you.
Hi everyone, welcome you all to today's session. We are really sorry you have to wait for some time. I think Dr. Natarajan will be joining anytime soon, maybe another 2 or 3 minutes. So if you are self-logged in, we will be starting soon. Good evening, Dr. Natarajan.
Can you hear me now?
Yes, sir, we can hear you. You can also switch on your video if
I've done that.
you want.
I hope you can see me.
Yes, sir, we can see you and
Okay.
your audio.
So this is like the usual Zoom platform,
Yes, sir,
right?
totally.
Give me a sharing rights, please.
I will just unshare this one, sir. Sir, before, while you put on your presentation, if it is okay, can I give a small introduction? Sure. Thank you. Good evening, everyone. On behalf of Boston Scientific, I welcome you all to today's session. We have a very esteemed guest speaker, Dr. K.U. Natarajan, with us today. Dr. Natarajan is a professor and chief consultant cardiologist and of Medical Sciences and Research Center in Cochin. Dr. Natarajan comes with over 25 years of experience in the field of cardiology. He is currently the president of Interventional Cardiology Council of Kerala and also electrophysiology and device therapy. Dr. Natarajan did his graduation from Madras Medical College, Chennai, and cardiology training from Chitra Institute, Trivandrum. Sir has over 10 original research publications and contributes. Dr. Natarajan is also a regular faculty in national level symposiums in cardiology and cardiac electrophysiology. With this, I would like to welcome you all to today's session and special welcome to
thank you very much for the kind introduction. I thank Boston Scientific at the outset, not only for inviting me to be a faculty for today's teaching session aimed at postgraduates and young cardiologists, but also participants to get an opportunity to delve into the field of device therapy, particularly pacemakers, because textbooks don't address the issue of pacemakers, how pacemakers work, how is a single chamber different from a dual chamber P, as well as troubleshooting, though it is covered in the standard textbooks of cardiology, are often not taught on a regular basis in the medical curriculum, whether it is MD days or whether it is DM days or DNB days. So it's a great thing in scientific, regularly contributes to this effect. So I thank Boston Scientific for this venture. And we will go into the subject proper. I'll share my screen. Let me know if you can see my slides.
Not yet, sir.
Can you see my slides?
Not yet.
Not yet? Once again. Share screen, desktop. Now can you?
Not yet. Sir, if you've shared the desktop, you'll have to open the presentation separately for us to view. Yeah, now it's visible.
Thank you. So in the next, the time allotted was from 8 to 9:30. It's a pretty long time, nearly 1.5 hours. I don't know how much you will be able to sustain concentration as possible. That's why I've coined the term pacemaker troubleshooting, a case-based practical approach. Rather than keeping it theoretical, I thought we will use some case examples to drive home some points as to normally, and if it is not functioning normally, what exactly is the problem? How do we diagnose the problem? With the aid of diagnostic tools like ECG, chest X-ray, fluoroscopy, a compatible programmer, and how do you correct the problem, either by changing the device settings or by revising the pacemaker or by revising the lead in varying combinations. So we will go through a case-based practical approach to this entire problem. So pacemaker, if a patient comes with complete heart block, with Stokes-Adams attacks, with recurrent syncope, it can be even fatal. So pacemakers can be life-saving in that scenario. They can largely contribute to improving quality of life. For example, somebody has sinus-related fatigue, etc. Putting a pacemaker can largely contribute to improving the quality of life of the patient. So it's very important to know that a right device should be implanted for the right patient at the right time. It's very, very important. And more than implanting a device, to ensure normal expected function of the device, as well as identify malfunction and troubleshoot whenever necessary. When I say normal function, you should always know how a pacemaker functions normally. Only can you know when it doesn't function to the expected level. That is very important. You should know how a pacemaker is expected to function. And when a patient comes for follow-up, you should answer the question way it is supposed to function. And if the answer is yes, you are happy. The pacemaker is doing its job. The patient is all right, and I'm happy about the whole situation. The next, functioning to the expected level. That means there is a problem. If that is the case, what is the problem? How to identify the problem, how to make a diagnosis, and how to sort out the problem. That is our aim of following up a patient with 4 case examples. The first example is rather straightforward. It is just to understand the system status. How is the pacemaker system? What is the status of this is illustrated in the first case example. The second case example is an interesting ECG observation. A patient comes with a device, you take an ECG, there is an interesting ECG observation. The third is an extremely difficult, a patient comes to the pacemaker, the pacemaker is probably not functioning normally, so there is an abnormality, but things are not straightforward. You are not able to identify the abnormality despite looking at the ECG. Looking at the ECG after keeping a magnet on the pacemaker, magnet ECG as you call it, chest X-ray, fluoroscopy, programmer, interrogation of the device using a compatible program, not the abnormality. A very vexing problem. Unfortunately, this happens very rarely, but I will highlight that particular case example. And lastly, a patient who had a device. On the 4 important case examples that I thought I'll start the presentation with. The first 3 I will show you. The 4th is actually, I thought I'll reserve it at the end in case we have time. And if anybody in the participant is able to give you a prize to make a correct diagnosis in the 4th instance. And if Boston Scientific has difficulty in giving you the prize, I myself will personally give you a prize. If one of you must stick on to the first 3 case examples. Is it possible to interact with the audience also? During my presentation, is it possible?
No, sir, the audience is usually on mute, but the audience can always raise their hands and I can unmute them from my end for them to speak.
Because this is a topic which is very practical. I'll be very happy if there is some audience participation, which will make it very, very exciting. So the first is a case example of a 56-year-old male, complete heart block, who underwent a pacemaker using a single chamber Medtronic device in 2003. He had elective replacement indication in 2011. So in 2011, the last follow-up was in November 2019. He had normal pacemaker parameters as well as lead parameters during the pre-COVID visit in November 2019. The final setting of the device was VVI 6 and 3 volt amplitude or the output pulse amplitude. So this is the setting. I again repeat, 60 per minute, 0.4 milliseconds pulse width and 3 volt output. This is the November 2019. And this was the ECG taken at that time. You can see VVI pacing at 60 per minute, normal capture. You can see the spikes here. Okay, I always look at all the leads very carefully. If you look at, you don't even see the spikes. That is why I always tell my postgraduates, look at all the 12 leads before you commit about whether it's a paced rhythm. There is a nice spike before the QRS in lead V2, V3, V4, V5, V6 at the rate of 60 per minute. Why do we say 60 per minute? There are 5 large squares between 2 consecutive paced QRS. 1, 2, 3, 4, 5. So 5 large squares means pacing at 60 per minute. So it was working at 60 per minute. And this is the magnet ECG. When you keep a magnet, the pacemaker goes into an asynchronous mode. So a VVI pacemaker will go into a VOO mode. Here was 85 per minute. All right. So this is the VOO rate of a Medtronic pacemaker. To the contrary, a Boston Scientific maybe 98, an Abbott device maybe 98 or 100. So it doesn't matter. So the fact of the matter is minute. And when we kept the magnet, it went into 85 per minute, which is what we expect. And we interrogated the device. We found that the battery status was okay. Lead parameters were okay. The lead impedance was 650. That's fine. This patient came to me for a follow-up today. This morning, I saw this patient. He came from Middle East. So this was today. The date is 29/1/2021. This patient is asymptomatic and we did an ECG like this. So I want you to, this is again a paced rhythm. I just want you to interpret this ECG for me. If somebody can raise their hand, I'll be happy. If somebody raises their hand, you let me clue. Look at the pacing rate. I told you this patient was left at VVI 60 per minute. The current rate of pacing is, previously you remember I counted 5 large squares. Now let us agree 4, and here is the 5th bold line. So the pacing rate is slightly more than 60. To be very precise, the pacing rate is 65 per minute. Per the ECG earlier, when we kept the magnet, it was pacing at 85 per minute. This is the magnet ECG. The first 3 beats is happening at 100. The magnet was kept here. The first 3 beats is 100 per minute. That is what is expected of metro per minute. Here, it goes into back to 65 per minute. So what is the inference? Why was this pacing rate at 65 per minute when you left the pacing rate at 60? The first 3 beats at 100, instead of being at 85 per minute, it goes into the pacing original rate of 65 per minute. That was the rate before you kept the magnet. What is the inference question?
Yeah, there is one Gaurav. I think Aju, you may unmute Mr. Gaurav.
What is your answer to the question?
And Sriram Agrawal.
Yeah, we will give the first opportunity to Gaurav, and then we will give the next question when we interact.
Gaurav, I have allowed you to speak. May you please unmute? Yeah.
Good evening, sir. Gaurav here from Thrissur.
Yes, please.
Sorry, was it a rate dependent? Sorry, if he's going on an exercise VVI or rate dependent mode?
No. The very fact that is only VVI, there is no R here. So that itself tells you that this is not a rate response pacemaker. I just want you to answer why the rate is 5 beats more than the programmed rate when it is not your clue. When you kept the magnet, the rate is only 65 per minute. Forget the first 3 beats. I want you to concentrate here. You want to make a second attempt?
I can see that intrinsic P waves
Gaurav, you will give the second. Intrinsic P waves have no relevance in a VVI pacemaker. The VVI pacemaker will pace the ventricle without caring about what is happening in the atrium.
60.
So that is not the correct response. Okay, Sriram Agarwal, you can answer.
Right.
You can unmute Sriram
Dr.
Agarwal.
Ram Kishore is another, and Mr. Naren is the other one who's there. Who is there.
We'll give one by one chance. As an answer, we will go to the next slide because we have limited time.
I can see only two raised hands, Naren and Dr. Ram Kishore.
Naren, can you answer? You can unmute him for a moment.
Yes, sir.
Am I unmuted?
Yes.
Sir, I probably think it is end of life battery.
So that's a correct. That's a correct answer. Only thing, a small refinement to your answer is it's not end of life. It is elective replacement.
Yeah, the battery on the lowest
that's
side.
Correct. So this is called end of life, or rather, elective replacement. At the time of elective replacement, the pacemaker switches to a rate of 65 per minute. After the first 3 beats, it will go into the same 65 per minute, not 85. Okay. So as you correctly said, this is a battery issue. This patient has reached ERI or elective replacement indication.
Yes,
so you
sir.
can again mute him. Okay. So this is a simple ECG which told you that there is the problem in this pacemaker. The battery has reached its replacement time. So the programmer, this patient, to be very precise, reached the ERI on the 21st of December. So from the date of reaching ERI, for 3 months, you have time to change the battery. If you don't change, within the next pacing may become erratic. And finally, what will happen is what you initially said, end of life of the pacemaker will come. Now the term end of life is not given because it has a negative connotation, end of life. So you call it, all right. So the rate was 65 because it reached ERI. We'll move on to the next case. A 47-year-old male had intermittent complete heart block, underwent a dual chamber pacemaker. This is a dual chamber pacemaker. The setting is DDDR, lower rate of 60, upper tracking rate of 130, maximum sensor rate is 130. And these are the output settings, the atrial setting and the ventricular setting. And this is the AV delay, which is not the observation. I just want you to tell me. This is the ECG before the pacemaker. You can see that there is complete AV dissociation, a narrow QRS escape rhythm. For this was the reason why the patient had a dual chamber pacemaker. During routine follow-up in June 2020, that is middle of last year, this was the ECG. I just want you to tell me what is happening in this ECG. One person can volunteer. I will just give a clue. If you look at these, if you see carefully, if you look at here, there is a nice spike before the QRS. There's a spike before the QRS. There is a spike before the QRS. So there is a spike before the QRS. So from here onwards, there is atrial sensed ventricular pacing. Every P wave in sinus rhythm is followed by a ventricular spike followed by capture of the ventricle. Spike is an indication of pacing output has successfully captured the ventricle. All right. So this is what is expected out of a dual chamber pacemaker. I want you to tell me what is happening here. In the procedure, what I want you to tell me. Now you can, whoever has volunteered can answer the question. Has anybody volunteered?
Gaurav.
I think Gaurav has raised his hand. I will just. Yeah,
Okay.
Gaurav, you can speak now.
Good evening, sir.
Sure, please go ahead.
Is it hysteresis was the mode, sir? Hysteresis mode allowing?
No, hysteresis was off.
Okay.
I will once again go to the settings of the pacemaker for you to understand. 60 is the lower rate. All right, right. I will ask you, I'll just give you a problem in the pacemaker.
No, sir, no.
Is there a problem in the pacemaker or is it normal function?
I think normal functioning.
Okay, you are correct that it is normal function. Now let us go back to this. All right. So let us say a sensed AV delay and a pacemaker spike should come here. Actually, there's a spike if you see carefully. There's a small spike here. But by the time the spike came, there was a spontaneous QRS. There is an intrinsic QRS, right? Now let us follow this P wave. There is a P wave here. That will set off a AV delay, a sensed AV delay. But before the sensed AV delay happens, after every P wave, even before the expiry of the sensed AV interval, there is a spontaneous QRS happening due to whatever reason. Obviously, these are not conducted beats. They are junction. This is very difficult to say whether it is conducted or not. It could be conducted, but definitely this is not conducted. This is not conducted P wave. This is not conducted P wave. This is also unlikely to be conducted P wave because they are very, very clean milliseconds. So this is what is called isorhythmic AV dissociation. So there is a native QRS right after every P wave. It may not be related to the P wave. So the pacemaker, though it sets off in there, the pacemaker is not able to capture the ventricle. Is that clear? So this is a normal pacemaker function. This is not abnormal pacemaker function. So looking at this, you should not think, Gaurav, I hope you understood what I said.
Yes, yes.
Okay. Okay. Let's go to the next ECG. So this is normal ECG function, normal pacemaker function. Lot of times, because of we think that the pacemaker is functioning abnormally. So this is actually an example of a normally functioning pacemaker, and there is nothing wrong in the pacemaker, right? And that is proved by keeping a magnet. Once you minute in this case example, and you see that there is a normal capture of the atrium and the ventricle at 100 per minute. So you know that this pacemaker is functioning normally. All right. Then moving on to the third case, which I told you, despite causes, we still could not arrive at an answer in this particular case. And I have to thank Boston Scientific by being extremely supportive when I was managing this patient, because it was extremely bitter. This patient got admitted nearly 15 times over a span of nearly 6 weeks. 15 hospital admissions over a period of 6 weeks. And this patient's family was devastated. I was equally devastated of medicine. If you cannot find answer to the problem, you really feel vexed as a clinician, because you need to know what you are dealing with. Once you know what you're dealing with, the power mind. When you don't know what is happening, then you are in deep, deep trouble. And that is exactly what this case taught me. And let us go to this case example. This is a 64-year-old male, diabetic, hypertensive, complete AV block. 10 years back, he had a pacemaker. He had a pocket infection. So his pacemaker had to be explanted. And we re-implanted with a new pacemaker, a new leads on the opposite side in May 2007. From the right side, we cut the lead and we abandoned the lead. And we removed the pacemaker, we closed the pocket, the wound healed well. And a few days later, we did it on the opposite side with a new pacemaker and new leads. This patient was doing very well. Settings, 60 per minute was the lower rate, 115 was the upper tracking rate. Both atrium and ventricle, these were the output settings, and these were the AV delays. They are not very important for this case. I'll just go to the next slide for you to understand transient loss of consciousness associated with clonic jerks on 28th of December 2019. That is again, before the start of the pandemic. He had an episode of transient loss of consciousness. After recovery, he had slurred speech, and his interrogation showed ideal parameters. Battery, because it was only 2017, 2-year-old pacemaker. Battery was okay, lead impedance was okay, threshold was both 0.5 in the atrium and in the ventricle. All was perfectly fine. He was admitted in Jan to frank syncope and fall with blunt injury to his scalp, etc. We interrogated the device. There were no atrial or ventricular high rate episodes. Atrial pacing was 28%. Ventricular pacing was all the time. Battery longevity was 12 years. Impedance was atrium 405, ventricle volt. So all perfectly fine. Threshold in the atrium was 0.7. Ventricle also was 0.7. And these were the settings I already told you. So everything is fine. Pacemaker is fine. But this patient has recurrent episodes. We did a 24-hour Holter in the Jan of 2020. 100% atrial sensed ventricular paced rhythm. Very few atrial and ventricular ectopics. We did a video EEG. There are no epileptiform abnormalities. Echo was readmitted again 5 days later with another 3 episodes of frank syncope. We interrogated the device, all ideal battery and lead parameters. We moved the device in the pocket. We made him do isometric chest Xing and things like that. And no change in the lead impedance. There was no capture failure that we could demonstrate. We are having a monitor ECG connected, and we made him do all kinds of exercise, hyperabduction of the shoulder. We manipulated the device in the etc. All was fine. We repeated a 48-hour Holter, not a single loss of capture. The maximum RR interval was 1 second. In view of the remote, there was already an abandoned RVOT lead, I told you. So we thought that the second lead also was lead and causing some over sensing. So we changed the sensitivity setting of the pacemaker. And this was the final settings of the pacemaker. We did a tilt table testing. It was normal study. Obviously, you don't look for bradycardia drop. There was no BP drop at baseline and on isoprenyl. He continued to have recurrent episodes of syncope. He was falling again and again. I did not know an answer to the problem. I couldn't identify a proper diagnosis. So on the 26th, I thought that we picked up the diagnosis. He told me that he had typical chest pain, suggestive of angina, before he had the syncope. So I thought, like a big hero, I thought that this is likely to be an acute coronary event, maybe a very critical disease in one of the proximal nears. You can have severe diastolic dysfunction. You can have syncope even in coronary artery disease. And true to what I thought, we did an angiogram and we found a critical proximal LAD 90% stenosis. The same setting, we fixed the LAD with, we finally fixed the problem and we were celebrating. I told the family that he's unlikely to faint thereafter. He was discharged. He was readmitted a few days later with again 4 episodes of pre-syncope. ECG was in the magnet. It was 100 per minute and A plus B capture was normal. And as you can see here, this is the ECG, which shows atrial sensed ventricular paced rhythm, all fine at the rate of 70 per minute. I kept the magnet, 100 per minute, DOO, atrium and ventricle are getting captured. X-ray, I just did an X-ray, we did a fluoroscopy. There was no obvious lead fracture. You can see that there is an abandoned RVOT lead, and these are the new leads that you see here. This is one of the atrial lead, which we tried to pull out the previous time interaction. And so I changed the sensitivity settings, but nothing made a difference. So now we did a 7-day continuous ECG monitoring, and that is how we picked up the diagnosis. You see this? This is the 7-day continuous ECG. ACE picked up the diagnosis. You see here, A sense V paste, A sense V paste. Then you see there's a lot of noise because the patient is probably having some jerky movements because of a Stokes-Adams attack. There is no ventricular activity here. Long ventricular asystole. I'm in a meeting. I'll call you back. Right. So if you can see here, the longest RR interval was 15.5 seconds. So for 15 seconds, this patient had a ventricular standstill. You can see multiple ponds to the atrial, the P waves here. All right. So this is when we picked up the diagnosis. Anybody wants to answer why this is happening? Any show of hands?
Oversensing.
Oversensing of what?
Of the clonic jerks, you give the history, sir.
Clonic jerk is because of anoxia activity. There is cerebral anoxia. You call it anoxic seizures. The jerk is not the reason for this abnormality. This abnormality is the reason for the jerk. It is the result
rather than the cause. Oversensing from old lead, but I think that has been ruled out by sir by increasing the sensitivity.
I reduced the sensitivity, not increase.
Increase the number, sorry.
I increased the absolutely right. Increase the number. So I made from 2.8, we made it 7.5 or something. Because it's anyway 100% paced, and I know that there's no intrinsic activity again happened. You should understand that oversensing will not cause 15-second pause like this. It can cause a small pause. It can cause pre-syncope. Here there is a problem either in the circuitry. We did not pick up anything on the interrogation. Sometimes these problems can be intermittent. Circuitry problems can be intermittent. Lead problems can be intermittent. So we changed. What we did was, now that we identified, we can't leave this patient like that. So what we did was, so that is a very alarming thing. But we were happy that we picked up the diagnosis. So we did a change of though the pacemaker had longevity of 10 years left, we removed that pacemaker. We put a new pacemaker problem or a battery problem. So we accepted the old atrial lead, but we put a new ventricular lead and a new pacemaker. And he's on follow-up for the last 1 year. He has never had a single syncope. So this was an example of, so you have to keep on investigating these patients, repeated ECGs, repeated Holter monitorings, external loop recorder, continuous ECG, all kinds of things you may have to resort to finally arrive at the diagnosis. What is the problem? Boston Scientific did send an explanted device to their industry, to their company. I have not yet got they could not really find any major circuitry problem is what I got from the mail communication from the head office in the US. Lead issue or a combination, we don't know what it is. Anyway, this patient is doing well. We arrived at a diagnosis, right? This is just to show that this is the new lead that I kept it in this, the mid-September that I kept it here. And this is what, and this patient incidentally came to me for a P21. You see atrial sensed ventricular paced rhythm. This QRS is pretty narrow because it is in the mid-septum. So this is what we nowadays routinely leave the ventricular lead in the mid-septum, and you get such narrow, beautiful QRS complex. As well, there is A paced, V paced rhythm at 100 per minute, and all is well. This patient is perfectly fine. He's extremely thankful, but I still cannot forget those traumatic days for this patient and desperate days for us. The problem is we fixed it within 24 hours, right? So with this background, let us go through a few points. The ECG is very helpful in a pacemaker per patient during follow-up. It helps you to answer is there a pacemaker at all in this patient by looking at the ECG. Obviously, you have the patient, the history is there, the scar is there, the patient is going to tell you that the patient has a pacemaker, but the ECG also helps you. After understanding the ECG, which chamber is getting paced? What are the expected normal functions of a pacemaker? Is the pacemaker functioning normally? For you to answer the fourth question, you will have to know pacemaker is not functioning normally. What exactly is the problem? First case example was a battery ERI. The third case was a capture failure or other pacing failure. How does the ECG help in this X-ray, fluoroscopy, and very important, a programmer? All these things we will go through using some case examples again. So as you all know, a pacemaker system has three components. Next, the pacemaker lead, which is the link between the pacemaker and the heart. In this cartoon, it is a ventricular lead. The third is never forget the patient. So the pacemaker assist lead and the patient. Why I'm saying the patient is because if somebody has a hyperkalemia, let's say somebody develops a renal failure and the potassium is 7.5, the pacemaker may be perfectly fine. The lead may be perfectly fine. Hyperkalemia increases the pacing threshold. So you have left at 3.5 volt. The threshold now necessary will be 10 volts, let's say. So the patient will come with loss of capture. So you should understand that you should never forget the patient. Some patients may take some kind of heavy metal, alternative medicines. All these things can affect the milieu of the case. So you should never forget the three components before you understand. And that is just the ECG. This is the program. The programmer is very important. The chest X-ray is a very important diagnostic tool, not to forget. The common types of permanent pacemakers are single chamber and dual chamber pacemakers. Single chamber pacemaker can be a ventricular pacemaker, we call it VVI, or a dual chamber pacemaker, we use the word DDD or DDDR if it is a rate response dual chamber pacemaker. And all of you know this code. What does that first letter stands for the chamber which is paced? So if it is a VVI, the chamber I, the second letter V is the chamber sensed. Here the ventricle is the chamber sensed. And the third letter, if it is inhibition, let's say, the third letter is inhibition, is what is the response to sensing? If there is an intrinsic VI means the ventricle is getting paced, the ventricle is the chamber which is sensed. In response to a ventricular sensing, it inhibits the pacing output. That is VVI. If it is an atrium, in response to atrial sensing, it inhibits the pacing output for that particular beat. Dual chamber pacemaker, the first letter D is dual. So it paces both the atrium and the ventricle. So it senses the atrium and the ventricle. The third letter is a little different. It is not DDI, it is DDD. Meaning, if there is an intrinsic atrial activity, it inhibits atrial output. If there is an intrinsic ventricular activity and AI pacemaker, here also an atrial intrinsic activity inhibits atrial output. An intrinsic ventricular activity will inhibit the ventricular output. But the only difference is in the third letter. The third letter stands for D. I will tell you the only difference between VVI, AI, and DDD is in response to atrial sensing. In response to atrial sensing, it triggers a ventricular pacing. It triggers a ventricular pacing. Atrial intrinsic activity inhibits atrial pacing output. Ventricular intrinsic activity inhibits ventricular pacing output. Intrinsic atrial activity triggers a ventricular pacing after a delay called as kept as 150 milliseconds after the P wave. If there is no intrinsic P wave, the ventricle will be paced at the end of 150 milliseconds. So I again repeat, a dual chamber pacemaker in atrial event inhibits atrial output. Atrial event, in addition to inhibiting atrial output, triggers a ventricular pacing after a particular delay called the sensed AV delay. All right, if it is 150 at the end of, if there's an intrinsic QRS before 150 milliseconds, obviously the pacemaker will not be pacing the ventricle. That is a different matter. We will talk about it later, right? So that is VVI, that is AAI, and that is DDD, right? So this is a single lead, and that lead is kept in the atrial appendage. And this is the ECG. As you can see here, you see this, there's a spike here, followed by a P wave. There's a spike here, followed by a P wave. Spike, P wave. But what is the P wave? Which is probably faster than the pacemaker's lower rate. All right. If you want to know the lower rate of the pacemaker, you can look at this. 2 consecutive P waves are there. 1, 2, 3, 4 rate of this pacemaker. That's what you see here. 50 is the lower rate of this pacemaker. But what is happening here is intrinsic atrial activity suppresses the atrial pacing output. So this is, forget that this patient has a dual chamber. I want you to understand the fact that in the absence of intrinsic activity, it paces the atrium. When there is intrinsic activity which is faster than the set rate of the pacemaker, it inhibits pacing. First is because there is intrinsic conduction. So the likely indication in this case is going to be, can anybody raise a show of hands? What is the indication for pacing in this case? Likely indication. Any takers?
Shakespeare syndrome.
Okay, fine. So that's a perfect. So next, move on to this. This is a ventricular pacemaker. You see a single lead, and the lead has been positioned in the right ventricular apex. And if you see here, there is ventricular pacing here, spike followed by QRS. Whenever you look at what happens immediately after the spike, if immediately after the spike you see a QRS, you're pacing the ventricle. If immediately after the spike you see a P wave, like you see here, this is it. And whenever there is an intrinsic activity, this is the intrinsic QRS there, it suppresses the ventricular pacing. So you know that this is a VVI pacemaker, right? And this is a dual chamber pacemaker. There is one lead in the ventricle here. The other lead is kept in the, these 2 examples. There are 2 leads here. So there's a dual chamber pacemaker. A dual chamber pacemaker can function in 4 ways. It can function in an atrial sensed, ventricular sensed rhythm, meaning if the atrial, it will inhibit the atrial pacing function. All right. So this is asensed, asensed, asensed. In response to asense, a sensed AV delay is started. But before that, there is intrinsic conduction to the QRS, the patient's the ventricle. All right. So this is asensed, V-sensed rhythm. The pacemaker is not even required at this particular point in time. Next is atrial sensed ventricular paced rhythm. You see, there is no spike before the P. That is because beat, a sensed AV delay starts. Upon expiry of the sensed AV delay, because there is no intrinsic conduction, a ventricular spike came here and that captured the ventricle. So atrial sensed ventricular. The third is the atrial rate of the patient is lower than the pacemaker's atrial rate. So it paces the atrium. You see a spike, you see a P wave. You see a spike, you see a P wave. you see a AV delay called a paced AV delay. Unlike this example where there is a sensed AV delay, here it sets off what is called a paced AV delay. But before the paced AV delay happened, an intrinsic conduction happened. All right. So this is an A-paced ventricular sensed rhythm. This typically happens in a patient with a sinus node dysfunction, as somebody correctly said. So this is an A-paced V-sensed slow. Atrial rate is slower than the pacemaker's rate, so it paces the atrium. And the AV conduction is also defective, so it paces the ventricle also. So A-paced, V-paced rhythm. So a dual chamber pacemaker can function rate and the status of AV conduction. The two parameters, depending on the patient's own atrial rate and depending on the patient's own AV conduction. Based on this, 4 permutations and combinations are AS-VP, AP-VS, and AP-VP. All these things are possible in a patient with a dual chamber pacemaker. It's interesting to know that in all the 4 situations, A-wave QRS, P-wave QRS, P-wave QRS. So AV synchrony is maintained in all the possible 4 scenarios in a dual chamber pacemaker patient. And that is how it becomes a better pacemaker, right? So with this background, so let us look at this example. What is happening here is atrium is getting paced, but the ventricle is being sensed. So this is an A-sensed, A-paced, V-sensed rhythm. All right. So atrium rate is faster. So this is atrial sensed ventricular paced rhythm. After every P wave, there is a sensed AV delay. Upon expiry of the sensed AV delay, you see ventricle. So it is an A-sensed V-paced rhythm. I will ask you a very pedestrian fundamental question. Why can't this be a VVI pacemaker? After all, there's a spike followed by a ventricle. This is not a VVI pacemaker and it is a dual chamber pacemaker. Can you find out a show of hands? Why can't this be a VVI pacemaker? I shouldn't be asking this question, but still I will ask. It's a very, very pedestrian question. Don't feel insulted when I ask that question. But let us keep interested.
It's a dual chamber pacemaker because of sensed and ventricle is paced. 1:1 connection. 1:1 means pacemaker is given a pace, ventricle paced. Atrial is almost sensed.
How do you know the atrium is getting sensed from the left to the right? That's what I'm asking. What should be? What should be your perfect answer be? Your perfect answer should be the spike. Throughout, if you see, there is a relationship between a perfect relationship between the P wave and the spike. This can never happen in a VVI pacemaker. All right, that should be your answer. You should be in every P wave and the pacing spike in the ventricle. So it cannot be a VVI pacemaker. Here, this ventricular pacing is in relationship to a P wave. That is why the P to QRS relationship, a VVI pacemaker cannot have AV synchrony. That is the correct answer. Your answer was correct, but I wanted you to say that there is a fixed relationship between the P and the QRS, right? So there's an to tell that there is atrial sense ventricular pacing, and towards the end, if you see, there is AP, VP as well. So this is a dual chamber pacemaker, right? So next we move on to the most important topic. ECG patterns may look like malfunction, but they are not actually necessarily be due to true pacemaker malfunctions. This is something you should be very, very cognizant of, because you may mistake it for a pacemaker malfunction when actually it is a normal pacemaker function. So okay, but things look abnormal, right? So this is a patient who had a dual chamber pacemaker, and you find that the RR intervals are not regular. So any takers? The clue is in what I've written there. Sinus tachycardia, 130 per minute. This is the next P wave. All right. The next P wave is here. There's one here. There's one here. There's one on this T wave. There's one before the T wave. So the P wave, the atrial rate is 130 per minute. But there is some irregularity in the ventricular rhythm. Though you have implanted a dual chamber pacemaker. I'll give you a clue.
The atrial tracking rate.
Absolutely correct. So as you correctly said, the upper tracking rate of this pacemaker was 120 per minute. So whenever you keep a rate is more than 120, there will not be one-to-one tracking, because the upper tracking rate can never be violated. A dual chamber pacemaker will never pace the ventricle at a rate more than the upper tracking rate in response to 80, whatever it is. But if the upper tracking rate is less than that, there will be something like, what is actually happening here? Can you tell me what is the pattern of AV conduction here? It's very interesting. I'll give you a clue. There are
2:1 AV block.
Not 2:1 AV block. In 2:1 AV block, the RR intervals will be constant. All right. It will be exactly half of the atrial rate. Here it is not constant.
It's 3:2 Ventricular.
Absolutely. 100% correct. I'll just take you through. This P, this is the sensed AV delay here. this P to this QRS, this pace rhythm is slightly longer, and this is not followed by ventricular pacing. This is followed by ventricular pacing. This P wave is followed by third one is blocked. This is contact. This is associate. This is ASVP. This is ASVP with a little longer interval. There is A, but there is no ventricular pacing. So for every third atrial sensed event, because the upper tracking rate was kept as 120, but the patient's rate, atrial rate, is more than 120. So here the pacemaker is not at fault. What is at fault is, if you want to have, you can make it. This pacemaker, this phenomenon will not happen. All right. Or if the sinus tachycardia is inappropriate, you can give beta blocker. This patient, this was recorded in the ECG room. This patient was not running. Beta blocker to this patient. All right. And after that, things settled. So the next case example of what looks abnormal, but it is not abnormal. A patient has sinus node dysfunction and an atrial pace, and the lower rate was kept at 75 per minute. Is the pacemaker functioning normally or abnormally? Show of hands. If possible, some other person to be given an opportunity. I request somebody else so that there is more participation.
So yeah. Abhishek Rathore, I think for the first time.
Answer the question whether this pacemaker is functioning normally. If it is functioning normally, what is exactly the problem here?
Hi, sir. Dr. Abhishek here. This pacemaker is functioning properly because we are able to see it's a P wave, but because this patient may have associated underlying AV node disease, so that is the reason that this pacing spike is not getting conducted to the ventricle.
This P wave is
waves are not conducted.
Okay. Yeah. So that's a very good answer. I really appreciate you, Dr. Abhishek. The ventricle. It can only pace the atrium. How can a poor atrial pacemaker take care of AV conduction? It cannot. So what, as he correctly said, the pacemaker is doing his job very well. After every spike, there is atrial capture. But this is captured the atrium, but it did not reach the ventricle because the patient's AV conduction system is defective. As he correctly said, he suspected an AV. That is an extremely correct answer. So here the pacemaker is not at fault. All this patient needs is to upgrade this pacemaker to a dual chamber pacemaker. That is the answer to that problem. Now, this is a VVI pacemaker, 30 per minute. I've given the answer already. The hysteresis was kept on at 40 per minute, meaning only when the ventricular rate is less than 40, the pacemaker will pace. And when it paces, it will pace at 60 per minute. But it will not. Even if there is 45, the pacemaker will not function. And the ventricular rate is 40 here. So here the problem is not the pacemaker. The hysteresis was kept at 40 per minute, and so the pacemaker did not function. So when we turned off the hysteresis, there is resumption of pacing at 60 per minute. We turned off the hysteresis. How can you have a pacemaker at 40 per minute? Somebody had wrongly programmed the hysteresis at 40 per pacemaker, or extracting the lead and putting a new lead is not the solution here. Here the solution is a simple click of a button. Switch off hysteresis, everything becomes all right. That's what happened here. So this is not a problem with the pacemaker. Here, this is a dual chamber pacemaker or a dual chamber device. The lower rate is 60 per minute. The upper tracking rate is 130 per minute, and AV delay is kept at 200 milliseconds. And a function called a managed ventricular pacing, wherein to promote intrinsic conduction, the AV delay of the pacemaker is increased even beyond the AV delay programmed. It can even go up to 400, let us say. Here the P to QRS is 400 milliseconds. Because we have optimized ventricular pacing, we have kept it correctly. I just want you to concentrate here and tell me whether there is something wrong here or something right here. This particular area. Any takers?
AV plus on here.
Pardon? What's your name? Can you identify yourself?
It's Sridhar here.
Please go ahead.
Sorry, AV search on here. AV search plus.
Okay, AV search plus is on. Correct. I just want you to tell me what has happened here. Is it normal or abnormal? This particular area, whether something is it normal or abnormal? That's all I wanted you to tell. Concentrate only in this P wave here. Where I kept the arrow, there is a P wave there. There is the P wave there. Now you tell me whether it is normal or abnormal. There is something called post-ventricular atrial refractory period. All right. So in response period in the atrial channel of a dual chamber pacemaker, so this atrial activity will not be sensed. This is actually an atrial ectopic. This is an atrial ectopic which will not be sensed by the atrial channel because there is something called post-ventricular atrial. There was a long gap here and the ventricle is getting paced here. So this is appropriate ventricular pacing. All right. So here the problem is not a loss of atrial sensing, things like that, because that atrial ectopic fell in the post, right? So the ECG also gives a clue. The next point, the ECG gives a clue to the indication for pacing and what is the underlying atrial rhythm. That's very, very important. This is a VVI pacemaker. There are multiple P waves here, and you have to look for a P wave outside the refractory period. This is a P wave which is not getting connected to the ventricle. This is just to tell you that the underlying rhythm is sinus rhythm. When I say sinus rhythm, we're talking about the atrium. There is a nice, beautiful P wave, heavy conduction, and so the ventricle is getting paced. And those are the P waves. So this is just to tell you that this is pacing the ventricle. You can see spikes here. Again, repeat. One look at the limb leads. You don't see spikes. So you may say that it is an idioventricular. If you look at V3, V4, V5, and V6, you can see a tiny spike before the QRS complex. So it's a ventricular paced rhythm. But there is no meaningful P wave. You can see some kind of a fibrillary P waves. So whenever you have like this example, such beautiful P waves, if you don't see such P waves, you should always suspect that there's underlying atrial fibrillation. Atrial fibrillation with complete AV block and a paced rhythm. Appropriate ventricular pacing. It can be either a VVI pacemaker. Tell me whether this can be a dual chamber pacemaker. Any show of hands? Straight, only one question. Can this patient be having a dual chamber? Though I have called it VVI pacing, can this patient have a dual chamber pacing? Somebody who has not answered so far can answer.
Rajiv. Hello, good evening, sir.
Yes, please. Yes.
If the ATR rate has crossed, that time the dual chamber can be in VVI.
What do you call that phenomenon as?
ATR, anti-tachy
no,
response.
It's not anti-tachycardia response. It is something else. I want you to tell me the exact appropriate.
Sir, Anugrah, your mode switch, sir.
That's correct. So Anita is perfectly right. So whenever the atrial rate, let us say, is above 180 per minute, all dual chamber pacemakers have a function called mode switch. When the atrial rate goes above 180, let us say, it will switch to only ventricle pace, mode. But for the purpose of today's understanding, let us say it switches to a VVI mode. That is exactly what has happened here. You call it as an automatic mode switch, or AMS in short. Unique to dual chamber pacemaker in response to atrial rates above a particular level. It's programmable. If you program at 180 per minute, whenever there's an atrial tachyarrhythmia at the rate more than 180, it switches to a ventricle only pacing mode. Right. Highlight that. Never forget the underlying atrial rhythm in a ventricular paced rhythm. That's very, very important. What is the practical relevance of that? Now that Anugrah has answered the question, he can answer this question as well. Why should fibrillation in the atrium? What is the therapeutic importance of that?
AV synchrony, sir, to maintain AV synchrony as much as possible.
AV synchrony is lost here. What is the therapeutic relevance I'm asking? If this patient has a high Charts-Vasc score, this patient is an indication for anticoagulation. Say that the VVI rhythm, all is fine, everything is perfectly fine, and send the patient home. But this patient can come with a dense hemiplegia. So if the patient has atrial fibrillation, just because a patient has a pacemaker, let us say you put a VVI pacemaker for a patient with a sinus rhythm and complete AV block, and some mistake in the past. That's why I'm telling you. These patients can come with a dense hemiplegia, and it can be fatal also. So this becomes an indication for anticoagulation, provided there is a high stroke risk, right? Now, the next important is already told you, whenever you see a spike followed by a P wave, the chamber paced is atrium. All right. And whenever you see a spike followed by a QRS complex, you know that you are pacing the ventricle. And whenever you have ventricular pacing relationship between the P and the QRS, it cannot be ventricle only pacing. It has to be a dual chamber pacemaker. So this is an atrial sensed ventricular pacing, which is not possible with a VVI pacing because there is AV synchrony here. So this is just to tell you that sometimes you may not be able to see spikes very clearly. So you have to be very careful. You have to look for, you have to search for all the leads. You have to see very carefully. This is a blown up ECG. If you see here, there is some spike here. In AVL, there is a spike. And there is a spike in lead 1. So what I'm trying to say is always look at all the 12 leads before, right? I just annotated the spikes. Now let us come to the next important point, value of the ECG with the application of magnet. Why are we all talking about a magnet ECG? All of you should understand that when you keep a magnet on the pacemaker site, it switches into an asynchronous mode, or it transiently becomes VOO. A VVI pacemaker will become VOO. It paces the atrium. The second letter O stands for no sensing. And when there is no sensing, obviously there cannot be response to sensing. So it is a A00 or V00. If it is a dual chamber pacemaker, this is the atrium, nor does it sense the ventricle. So that is what happens when you keep the magnet on a pacemaker. It transiently switches to asynchronous mode. This is how you keep the magnet. This is what we said as a reed switch. It becomes A00, we call it AOO. VVA becomes VOO, DDD becomes DOO, meaning asynchronous or does not have any sensing function. It suspends the sensing function. Not only it suspends, each company has its own magnet rate. For example, Medtronic has 85, Boston may be 100, Abbott may be 100. That's why you should know about how a pacemaker behaves depending on the make. The manufacturer also is very important. It also indicates the battery. It terminates PMT. We won't go into the details currently. This is a VVI pacemaker at 70 per minute. When you keep the magnet, it is accelerated to 100 per minute. This is an AAI pacemaker. You can see that there is an atrial spike followed by atrial capture rated to 85 per minute. All right. So this is obviously a AOO mode. This is a dual chamber pacemaker. As you can see here, there is atrial sensed ventricular pacing to start with. When you keep the magnet, it is accelerated to 100 per minute. All right. And it captures not only the dual chamber pacemaker, which has transiently gone into a DOO mode. Right. Now let us get to the next most important question. We were actually supposed to talk about troubleshooting. We should always know what is normal before you talk about what is abnormal. So we spend some, now let us answer the question, is the pacemaker functioning normally? What are the normal pacemaker functions? There are three important pacemaker functions. One is called the pacing function, that is delivery of a pacing output. To deliver a pacing output. And how do you know a pacemaker has given its output? On the ECG, there will be a spike. The spike tells you that the pacemaker has delivered an output. That's called pacing function. The next question is, the next question. That's called capture function. If there is a spike followed by a P wave, the atrium has been captured. If there is a spike followed by QRS complex, it has captured the ventricle. So that is called capture function. So if it depolarizes the chamber concerned, you say capture function is all right. The third important function is sensing function. What is sensing function? When there is an intrinsic cardiac activity, has the pacemaker appropriately. If it is a VVI pacemaker, in response to ventricular sensing, it should inhibit ventricular pacing. If it is an AI pacemaker, in response to intrinsic atrial activity, it should inhibit atrial pacing function. If it's a dual chamber pacemaker, AV delay. So that is called sensing function. So I repeat, the most important three functions are pacing function. The ECG equivalent of a pacing function is the pacing stimulus artifact or the pacing spike. Capture, is it followed by a P wave? Is it followed by a QRS complex? Answers the question whether there is capture. The third important function is sensing function. When there is intrinsic QRS complex, there should not be pacing of that chamber. There being an intrinsic activity, if you still see a pacing spike immediately after that, that means there is undersensing. Undersensing causes overpacing or inappropriate pacing. Oversensing causes prevent a pacing output. All right. So oversensing will cause underpacing. Undersensing will cause overpacing. It's not correct grammar to say overpacing and underpacing and all that. It is not correct English. Undersensing causes overpacing, unnecessary pacing, pacing when it should not be pacing. Whereas, I don't know whether I told it correctly. Oversensing causes underpacing. It will not pacing. Undersensing, overpacing. Oversensing, inhibition of pacing. All right. So these are the three important functions that you should address when you have a pacemaker, a patient coming to you for follow-up. Is the pacing function all right? That's what we are interested in. For pacing function, you need an intact pacemaker battery, and there should not be oversensing of undesirable cardiac or non-cardiac signals. When there is oversensing, there will be underpacing, I already told you. So, and there should not be any oversensing, all right, for a normal pacing function to happen. Some of these things may appear complex, but once you keep on seeing pacemaker patients, these things will become very, very ordinary facts. Pacemaker battery, you need an intact lead with an intact conductor and an intact insulation, an ideal lead position, either in the atrium or in the ventricle, and the chamber should be excitable at the point of contact of the lead to the chamber. All you need an intact pacemaker battery. Let us say a pacemaker battery is completely gone. A pacemaker was implanted 15 years back and it has reached end of service. There will not be capture. You need an intact lead. You need the connection between the battery and the excitable at that particular point. Only if all these things are there, there can be capture. For sensing function, again, you need an intact pacemaker battery because sensing is also a pacemaker battery function. Next, again, you need an intact lead. You need an intact lead with an intact for the signal from the heart to be transmitted to the pacemaker. Only when the signal from the heart is transmitted to the pacemaker through an intact lead will the sensing function be all right. So you need an intact lead of the local electrogram at the point of lead contact in the, let us say you put a lead in the ventricle and that local ventricular signal is only 1 millivolt. Obviously, there will be undersensing. So these are the three important prerequisites for a normal capture function. You need an intact battery, you need an intact lead, and the chamber should be excitable. For sensing function, you need an intact battery, you need an intact lead, and also you need good signals where the lead is in contact with the chamber. All these things are important. First function and pacing function can be hampered by oversensing. Please understand, oversensing is one of the reasons for loss of pacing. The next important function is capture. There is a spike, but there is no P. There is a spike, there is pacemaker, spike and no QRS. You say pacing is normal, but ventricle is not getting captured. That is your interpretation. If no spike is seen, your interpretation should be loss of pacing. Spike is seen, no P, capture is lost. The third important thing is, in spite of there being an intrinsic activity, the pacemaker is unnecessarily pacing. The answer is under sensing, right? So what is the defect? When there is an abnormality, what is it? I already told you, it's called loss of pacing function. The two important things for loss of pacing is battery failure or oversensing. Loss of capture can be again battery depletion, or it can be high capture threshold due to a lead fracture or an X. Right. Now, can you tell me if somebody has oversensing and because of that, there is loss of pacing output? Can you tell me a simple bedside maneuver which will answer the question, whether it is somebody answer that question? There is loss of pacing output. When there should be a pacing output, there is no pacing output happening. So it is a loss of pacing output. I'm telling you the reason for the loss of pacing output is oversensing. Can you tell, answer the question whether the battery is at fault or is it oversensing? Battery is okay. Something is getting oversensed. Anybody wants to answer that question?
Sir, by placing the magnet?
Absolutely correct. If you keep a magnet on the pacemaker side, battery is not the problem. It is oversensing because, as we already discussed, when you keep the magnet, you are suspending the sensing function. So if oversensing is the reason for loss of pacing output, by sensing output, not capture, receive pacing output. So here the problem is oversensing. In spite of keeping the magnet on the pacemaker, the problem persists. It is not due to oversensing, it is something else. All right. So rhythm is slower than that of the pacemaker, but the pacemaker does not give an output. You say pacing failure. In the ECG, this will be shown as an absence of spike. If you look at this example, a spike should have happened here, but there is no spike. For a capture failure, what will be your answer? Is it pacing failure or capture failure? Any takers?
Pacing failure, sir.
Yes. Your answer is absolutely right because there is no output. You see, there is a nice pacemaker spike. So it is pacing failure. You should not use the word capture failure. You should use the word pacing failure. If it is due to oversensing, if you keep a magnet, this problem should be sorted out. Right? So there is no output there. So again, it is either a pacing output failure or it could be oversensing. One of the two is possible. So when we keep a magnet on the pacemaker, if there is oversensing and that is the reason for loss of pacing, here a patient has a VVI pacemaker at 70 per minute and the patient's intrinsic rate is 50 per minute and there is no capture, there is no pacing output. So I'll again ask the question, is it a pacemaker has been programmed to 70 per minute, hysteresis is not kept on. Pacemaker is kept at 70 per minute, but the patient is having CHB with a ventricular rate of 50. In spite of that, the pacemaker is not pacing failure.
Pacing failure, sir.
Yeah, because there is no spike. So let us keep a magnet. And this is what you achieve by keeping a magnet. So what is the reason for this problem?
Oversensing.
Excellent. Oversensing, I again give you the under pacing. Pacing has not happened as it should be happening. So it's under pacing. And when you keep a magnet, things get sorted out. So this is due to undersensing. Whereas if you keep another issue, it is not due to oversensing. Here it is a textbook definition of oversensing as the reason for pacing failure. So now let us go to loss of capture. Pacemaker gives an output during bradycardia, capturing the chamber, even if it is not refractory. This is called capture loss. Spikes are not followed by P or QRS. So here, let us see this example. Here is that I'll give you no QRS. There is a spike here. There is no QRS. There is a spike here. There is a paced QRS. Spike, no QRS. Spike, no QRS. So I'll ask you the question. Is it pacing
Capture
output failure or? So here the problem is it complete loss of capture or intermittent loss of capture?
Intermittent loss of capture.
Intermittent loss of capture. The pacemaker was implanted 14 years back. So what do you think is the reason? You are almost reaching end of service. It is not reached end of service. That is why some last ounce of battery is still there. That is why at least once in a while it is capturing. This is due to some giving output. It is giving output. After some time, the output also will disappear, right? So this is an example of a spike without capture, right? And when you check when you interrogated the device with the programmer, ohms. I want you to understand that when you interrogate a pacemaker with the programmer, there are two impedances that will come into the picture. One is battery internal impedance. The other is pacing lead impedance, UC4, which is normal. So here it is, I want you to understand that there's something called a pacemaker battery internal impedance. If it is 34,000 ohms, that means the battery is almost dead. Okay, So you have reached end of. This is not a lead problem. This is a battery problem because the lead impedance is normal. So what is the solution to this problem? What is the solution to this problem?
Battery replacement.
But replace the battery.
No,
Should
sir.
you replace the lead also? Unlikely that this patient will need a lead replacement because the lead impedance is normal. Make a change. That's a different matter. This patient is a dual chamber pacemaker implanted for complete heart block. There is atrial sensed ventricular paced rhythm. What is the problem here? There are a lot of gaps here. What is the problem here?
Oversensing, sir? Oversensing of beats?
Oversensing of what? You mean to say that told you oversensing will inhibit pacing output. All right. If you look at this here, look at this particular. That's why I again repeat, look at all the leads. Don't look at only the rhythm strip. Look at the V4 to V6 EG. So there is a P wave here. So there is atrial sensing and there is a ventricular pacing output here. So you should never use the word oversensing. Oversensing will cause loss of pacing output. Pacemaker output is there. So what is the problem here?
Capture.
There is loss of ventricular capture. Now I'll ask you the question. Is it complete loss of ventricular capture or intermittent ventricular loss of ventricular capture? Atrial sensed ventricular paced. All throughout there is atrial sensed ventricular pacing. Every P wave is followed by a sensed AV delay and a spike. This is not the lead to look for the spike. They're all simultaneous. So if you have taken a V6 rhythm strip, you would have understood it even better. But believe me, there is atrial sensed ventricular pacing throughout the case. This atrium is also sensed. So there is atrial sensed ventricular pacing throughout, but there is intermittent loss of ventricular capture. Is that clear? All right. So this is intermittent loss of ventricular capture in a dual chamber pacemaker. And that is loss of capture, intermittent loss of capture. And this patient was interrogated. What is the mistake in this interrogation? I have actually made it simple for you. The atrial lead impedance is 500. This is the ventricular lead impedance. This is normal. Very high ventricular lead impedance. What does this mean?
Lead fracture.
There is a lead fracture. Whenever there is a lead fracture, the ventricular lead impedance will be higher. Whenever there is an insulation breakage, the impedance will be
low.
Impedance will be low. So it will be, let us say, normal impedance. If it is less than 300, it is low. If it is more than 1500, it is high. So this is an example of a high impedance. So the answer is lead conductor fracture. The metal conductor has broken here, abnormally low. Right? And you did a fluoroscopy or an X-ray or whatever it is, you can see that there is lead fracture here. This is the intact lead here. You can see a thin lead fragment here. So there is a lead fracture here. Now the third important thing, undersens overpacing. Undersensing causes overpacing means it will give an output when it should not be giving an output. So let us look at this example. This is a VVI pacemaker kept at 60 per minute. So here there's a spike followed by a paced QRS. There is an intrinsic QRS here. It should have inhibited the pacing. But what has happened here? There is a pacing spike in spite of an intrinsic, in spite of a QRS being there. There is a pacing spike here. In spite of an intrinsic QRS here, there is a pacing spike here. So there is over-pacing spike here.
Undersensing.
So what is the answer here? Undersensing.
Yes, sir.
Will not help. Here the problem is not over-sensing. It is undersensing. So keeping a magnet will not solve the problem here. Only when there is a over-sensing related loss of pacing would not help. You have to change the sensitivity settings for this problem should to be corrected. All right. So I again repeat, this is an example of over-pacing. In spite of an intrinsic QRS 60 per minute, right? If you look at the spike to spike interval, it is constant. Wherever a spike should come, it is coming, irrespective of whether there is an intrinsic QRS or not. So it is a undersensing. I'll ask you the question. Is there loss of capture here? There is a spike here. There is no QRS. There is a spike here. There is no QRS. So can we also say, not only is there undersensing, there is also loss of capture? How much of capture?
Yes, sir. It's in refractory period.
That's correct. It is refractory because there is a preceding QRS complex here. So this is not loss of capture. It is called physiological loss of capture. The capture did not happen because of a problem, or it can be a malignant problem. Anybody?
It can be a malignant problem, sir.
In what way can it be malignant?
It can induce ventricular arrhythmias.
It can induce
ventricular arrhythmias, sir.
It can induce ventricular arrhythmia by, if, let us say, the spike fell here and it captured the ventricle. It is something like a R on T phenomenon. So as you very correctly said, it can even cause death. I've seen patients coming with the burnt chest because of recurrent polymorphic ventricular tachycardia. When I say burnt chest, DC verted some 15-20 times and then referred here. All that was needed is to change the settings and everything will be corrected. So here magnet will not solve the problem, right? So what we did was, so here you have to increase the sensitivity setting. So the minute you do the sensitivity setting increase, look here, there is an intrinsic QRS, but there is no pacing here. So we have sorted out the undersensing issue by all the intrinsic P waves now are getting correctly sensed. So we have corrected the problem by using the programmer. What is happening here? This is the last of our case example. We already reached 9:40. We started a little late. I told you that there's a prize question, but then there's no time for that. So not because I don't want to give you a prize. I'm actually willing to stay awake till even 10:30, 11 o'clock. But any meaningful student's concentration gets prolonged beyond half an hour. Your concentration will get compromised, and these are all very complex matters. So you should spend enough time. Slowly, we should be progressing in our understanding. So we should not cram our brains with too much of info. This is a dual chamber pacemaker. This is a dual chamber pacemaker. What is the problem here?
P wave undersensing, sir.
Pardon me?
Undersensing of P wave.
That's correct. So you see, there is a P wave here. In spite of a P wave, you see there is an atrial spike here. There is a P wave here. There is no relation. Lower rate of 60 per minute, there is an atrial spike and a ventricular spike. There is an atrial spike and a ventricular spike. There is an atrial spike and a ventricular spike. So throughout this example, there are two rate of 60 per minute. When in reality, the patient's atrial rate is much more than that. Let us see the patient's atrial rate. This is one P wave. This is the next P wave. This is a P wave. This is a P wave. So if you have a caliper, I can prove this for you. So the patients, if the atrial sensing was all right, this patient will be pacing in what mode?
A sense V pace.
At what rate? At 80 per minute. Because this patient, I measured the PP interval, it is 80 per minute. So this patient, if the atrial sensing function was all V paced mode at 80 per minute. To the contrary, here the atrium and the ventricle are getting paced at the rate of 60 per minute. Now I'll ask you the question, is there atrial capture at all?
No, sir.
You should look at a place where the atrium is not refractory. There is atrial capture here. There is no capture here because the atrium is refractory because of the intrinsic P wave. Here there is capture. Here there is no capture. Here there is capture. So whenever the atrium is available for capturing that atrium. So it's only a sensing problem and not a capture problem. All right. So there is atrial undersensing, as you correctly said. But whenever the atrium is not refractory, it is capturing. Whereas refractory. So let us not complicate matters. As you correctly said, here the sinus rate is 80 per minute, but there is no ASVP rhythm because the atrium is not getting sensed. So it is pacing at the lower ventricle is getting paced together. Whenever the atrium is available for excitement, the atrium is getting captured. Otherwise, the atrium is not getting captured, but there is absolutely no sensing of intrinsic P waves. Nowhere in this rhythm, there is atrial sensing. So there is loss. Improve the atrial sensitivity, or you may have to even reposition the atrial lead for things to improve. So this is a textbook example of an atrial undersensing in a dual chamber pacemaker. All right. Is there ventricular sensing here? Is there ventricular sensing here? Can anybody answer that? Is there ventricular sensing here? To answer that question, you need intrinsic QRS complexes. Only then you can answer the question. There is no intrinsic QRS in this case. All the QRS complexes are due to ventricular pacing. So you cannot all are paced QRS complexes. Only when you have an intrinsic QRS, you can answer the question whether there is ventricular sensing or not. Here you can only say that ventricle is getting captured normally. All right. So any question? We saw some 3 important case examples where one was an ERI reset. Ventricular pacing was kept at 60, but the patient has a ventricular pacing at 65 per minute. When you kept the magnet after the first 3 beats at ERI. The second was an example of a junctional rhythm, which was following every P wave. And so the pacemaker was not, the dual chamber pacemaker was not pacing the ventricle, but it is normal pacing behavior. That is the second ECG example, where the patient was coming with a dual chamber pacemaker with recurrent episodes of syncope, but your pacemaker interrogation was normal. All ECGs were normal. Only a prolonged ECG monitoring for 7 days brought out the prolonged ventricular standstill, either due to a battery problem or due to this, we revised the lead as well as the battery, and the patient is asymptomatic thereafter. Then we've answered some questions as to how the ECG helps us by identifying the chamber which is getting paced. If there is a spike followed by a P wave, it is pacing, and the importance of AV synchrony to differentiate between VVI pacemaker versus a dual chamber pacemaker. We identified 3 important key issues as functions of the pacemaker. Pacing function is reflected by a spike, but there is no when there is no chamber excitation. So that is capture failure. When there is no spike, it is pacing failure. When there is spike, no depolarization, it is capture failure. The third is sensing problem, under pacing. And the problem will be corrected by keeping a magnet on the pacemaker. Under sensing means unnecessary pacing. In spite of a QRS complex being there, it still paces the ventricle. That is under sensing. That can be dangerous because it can with the sensitivity settings. If it is under sensing, you improve the sensing. If there is over sensing, you correct whatever is the reason for the over sensing. So I'll stop here. If there are any questions, you can ask me. We are almost more than 1.5 hours vacation. Because I don't want to rush through that price question. We will, if Boston Scientific is kind enough, we can have a part 2 of this session after a month or so, and then we can address that particular question. That's a very exciting case for you to understand things.
We've already started getting requests to plan another session and recording of this session. So surely we would be more than happy to have you again with us. There is a question in the chat box. Pacing spike is present without atrial or ventricular depolarization. Dr. Abhishek Rathore.
See, first of all, that pacemaker was a VVA pacemaker. So let us not talk about atrium here. So the answer to the question and your understanding also becomes simplified because it's only a ventricular pacemaker. So forget about. So what was your? Can you repeat the question once again?
When battery is depleted, why it happens that pacing spike is present without atrial or ventricular capture? Probably I think they're asking about spike, presence of spike.
There is a spike, but you have programmed the spike to be 3.5 volt. Because the battery is almost dying, the spike only reflects some kind of an volt output. But what the pacemaker is capable of delivering may be only 0.4 volt output because the battery is dying. You have programmed it to be 3.5, but what is delivered is sub-threshold output. Let us say the threshold was only 0.5 because the battery is only capable of delivering 0.5 volt. But that 0.5 volt is capable of giving a spike on the ECG. It did not capture because it is sub-threshold output.
Yes, sir. Thank you, sir.
I hope I have answered. Okay, all of you can jot down some questions and let us have your questions. And the next session, we will finish in about 45 minutes time and we will have sufficient question and answer. We will finish this particular chapter. First 45 minutes, we will have some continuation of this particular thing and we'll finish the chapter. And I'll also introduce that price question for you to answer that question also. And we'll give you an award at the end of that price question. And then we will devote only for answering questions. I want you all to note down a lot of questions. I'm sure you'll have a lot of doubts. The more you have doubts at the end of today's session, the more you have understood. That's what I would say. Always tell my PGs, please ask questions. Because the minute you start asking questions, you have started thinking. The minute you start thinking, you start developing doubts. The minute you start developing doubts, you start questioning. And the minute you start, will become lesser and lesser with passing time. And a stage will come, your questions will become extremely minimal. Instead of asking 100 questions, at the end of 5 years, you'll ask only one question at the end of a talk. And that will be the most difficult question for the speaker to answer actually. So please keep thinking minutes of the next session purely to answer your questions. Let them be the most silly of questions, doesn't matter. Always a young mind will ask silly questions, does not matter. It is asking questions which is more important. Ask questions. Thank you for your kind attention. So Boston, if you are kind enough, we can have one more session at some other time in the future so that we can finish this.
I think on behalf of Boston, I can say that, it will be our pleasure. And there is a lot of requests in the chat box regarding the recording, as well as reach out to you to check about the timings. And we'll ensure that everybody who attended today's session will be a part of that next program as well. We'll extend the invitations as well.
Thank you so much for your kind attention. Good night.
Good night. Thank you so much. Arzu would like to conclude.
Yeah, Rahul, thanks. Thank you so much for joining, sir. And we've had a very good response on the chat today, and we would love to have you for another session and sometime soon. And you enjoyed addressing our lovely audience.
Yeah, I always enjoy teaching. Thank you for the opportunity that you gave me.
Thank you so much, sir. I think there are no more questions. We'll be sending out the recording soon, I think in another 2 or 3 days. And if you may allow, sir,
Sure.
Thank
you very
you
much for the opportunity.